what I talked to you about today is the essentially back pain and hip arthritis, and we coin them as a hip spine syndrome. Nothing to declare. I suppose this is a clinical scenario that you provide when you see patients in your rooms or in the clinic. Patients come in with back pain and a bit of leg pain as well. And then after examinations and taking a good history, you do an X-ray and it shows osteoarthritis of the lumbar spine and osteoarthritis of the hip. And I suppose going through your mind, which is the differential diagnosis, whether it's mechanical back pain with a bit of referred pain from the facet joint arthritis, or could be mechanical back pain with radiculopathy, depending on the level that you have the impingement. And then you got a variety of other differential diagnoses, whether it's referred from the pelvic pathology or abdominal pathology, and then if you don't find anything else, you tend to blame the piriformis, sacroiliac joint, or if you're rheumatology inclined, you might think that myalgia rheumatica or auto syndrome. But today we mainly concentrate on hip and spine osteoarthritis. So back pain is a very common condition. Its incidence is 73%. And I believe that the other 27% probably just can't remember they had back pain in their life, but essentially it's a very common condition. Point prevalence is 12%, and I'm quite sure that in our room here, there will be a few people suffering from risible back pain that I know of. 1 month prevalence is 23%, and for these patients, if we do X-ray for all of them, nearly 60% of them will have some degenerative changes in their lumbar spine. Compare that to hip pain, which is much less common. The incidence is about 3%, a bit more than 3% of people of 55 years of age. I suppose that means above our average age group here. The prevalence is about 7% in male and 10% in female. I'll just go through this definition of hip pain because I want to make sure that people kind of have no confusion. So essentially hip pain is described is the groin pain, a little bit down to the thigh, mid-thigh, and including the lateral aspects of the hips as well. Obviously, it could be bilateral or unilateral. So in terms of hip arthritis, there was a paper done in 2005, and they interviewed 1,071 people from the general population, and they also did X-rays, and they found that 16% of people of 45 years of age will have severe degenerative changes in their X-rays of the hips. Of these, only 20% of men at the age of 45 to 54 has hip pain. And the correlation between symptoms and the X-ray is a bit more better at the age when you're over 55 years of age. So that means not all severe arthritis or hips are symptomatic. And that obviously go back to the question whether these are symptomatic or they are relevant clinically or not in your rooms. So why are there more hip surgeons than back surgeons? Obviously, back conditions more common, but I suppose look around the room here, other boys, I can see there are more hip surgeons than back surgeons. So we go now to the clinical scenario that I talked to you before. It's a presentation of back pain and hip pain, and it's a common condition. It's we find that people with hip pain, 30% of them do have symptomatic back pain as well. It's a diagnostic problem and a management problem. Today is mainly to talk about how to identify the problem, how to go about with it, but we're not going to talk about the management of these conditions today. So the pathogenesis of symptoms, as you probably now I suppose always been trained that the hip pain refer to the groin pain, anterior thigh, buttock, and medial aspect of the knee from the irritation of those nerve running across the knee, across the hip. In terms of radiculopathic pain, then the pain obviously from the lower back goes round to the buttock area. It can go to the thigh, medial knee, plus or minus associated neurology, weakness, numbness around that area. Both they have problem with shoes and socks. For clinical signs, both have antalgic gait. In terms of radiculopathy pain, they do have reduced knee reflexes, reduced sensation over the thigh, maybe to the shin. Quadricep weakness, tenderness, and I suppose the most important thing is the femoral nerve stretch test will be positive. In terms of hip pathology, leg length discrepancy, flex flexion contracture, internal rotation, either limitation or irritation with internal rotation, and quadricep wasting. So which is which? 2008 rheumatology journal, there was a study that they tried to make sense, they tried to make scientific of of this clinical symptom and sign, and they found that if there is a limp, groin pain, and limited internal rotation of the hip, so more likely to be hip as a major source of pain. But if they have a positive femoral nerve test, limited external rotation of the lumbar spine, and obviously some neglect neurology and the spine is a major source of symptoms. With that, McNabb before that we go to investigation. So investigation is mainly X-rays, CT, MRI, bone scan, and nerve conduction study and EMG. In terms of X-rays, I always do X-ray erect position with flexion extension, because the erect position can show us the alignment as well as the any evidence of instability that could explain the symptoms a bit better than just a supine X-ray that GPs tend to organize for us. So really, when you presented with a patient with an osteoarthritis of the hip and the back, and then you wonder where the pain comes from, the diagnosis mainly relies on the history and the clinical examination that you've done. So we'll go through a few cases. This is the 78-year-old female. She came in with back pain and again groin pain down the thigh. I didn't put a scalp view here, but the MRI scan this is the level. I suppose you can see that the level here is the L3-4 when she had stenosis on that side, on the right side. Again, an X-ray was done. Thank you. And she really, this is a weight-bearing view. She may have minor venial pole narrowing of the joint, and she went on to have initially conservative management first with this, with physiotherapy, injection, and later surgery when they failed, and she had good results. This gentleman, as you can see, he's quite obese. You can see through all the fat layer. You can see the severe arthritis of the joint, both sides. And he also had a bad spine as well. His symptoms is mainly due to hip problem, and he had hip replacement, and he done well. This is another patient, a female. She came in with severe back pain. An X-ray was performed, and you can see that she got severe arthritis of both hips. The other thing that I noticed is if you look at the X-rays of the pelvis here, this is a weight-bearing view standing, and you really see nearly like pelvic outlet view, meaning that the patient had severe contracture of the hip As a result, the hip had to tilt forward, and she had severe back pain due to this. So this is really secondary hip pain syndrome. She had an MRI scan, and everything was clear on the back, in the back, apart from the fact that she had osteoarthritis of the lumbar spine. So we go to hip pain syndrome. McNabb in 1983, I think, he coined this syndrome as a hip pain syndrome. So he divided into four types. The first one is a simple one, whereby there's a clear clinical presentation of hip pathology or spine pathology as separate. And then for these, it's a matter of whether asking the patient whether the symptom is more severe, and you go ahead to treat that as a primary management. And they do quite well. Second, type 2 is the complex one, and the patient come in with back pain, leg pain, and they're both severe. And even after the examination, and it's not even clear which is more severe, scans reveal pathology for both. And for these, they recommend target injections. So I usually start off with the hip injection with anesthetic and get them to do some walking right after that. And obviously, if the patient say, "Oh, it was amazing," the word after is amazing, patients just feel really good after that, then obviously the hip is the trouble. If they just say, "Oh, a bit better, still have trouble," then I go proceed with the second injection, which is the either a steroid injection or with anesthetic into the spine is either an epidural injection or nerve injection, depending on the level of the impingement, and usually it's clear from there. The third type is the secondary hip spine syndrome. And this is due to the interrelated spine and hip pathology due to misalignment of the spine or the hip. And this is the first one is the fixed fractional contracture of the hip, as the third case I showed you before. Patients with severe hip contracture will tilt their pelvic forward to stand straight with the knee. Because of that, they actually tilt their alignment forward in the spine. If the spine is flexible, they'll be able to arch their back and keep the center of gravity along in a straight line. And due to that, due to hyperextension of the back, they close up the foramina of the lumbar spine. And if they have borderline stenosis of the spine, that will cause severe impinging of the nerve roots and causing the problem. And with that, if you fix the hip, the spine will get better. On the other hand, if you have flat back syndrome, which is a condition due to severe arthritis of the lumbar spine or failed back surgery where the spine was fused in a straight spine without the lordosis, in that way, because of flat back, it brings the center of gravity forward and cause severe pain in the back. If the patient have hip problem, especially in the posterior pole of the hip, it actually can bring on your hip pain arthritis as well. So in this way, if we fix that flat back syndrome, that will help with other problems as well. Similarly, in terms of coronal alignment, with fixed adduction contracture of the hips or scoliosis with pelvic obliquity, if you try to do the same thing, it will help. This doesn't mean surgery though. I mean, you can actually have a heel raise on your foot, or if you could try to use a brace to support the muscles, which is now unequal, that will help with the pain as well. So I suppose this is the most important slide in my talk here, which is the conditions that tend to be ignored. And then the type 4, which is the misdiagnosis. You see a patient that's been referred from another surgeon whom the probably incorrect order of the surgery was done. Typically, we had a patient recently come in after laminectomy and turned out to have septic arthritis of the Birmingham hip. So obviously, when we fixed that, the patient got better. So it's just briefly about treatment. So obviously, you treat them according to their major symptoms. And for training, well, with surgeon, we always treat them conservatively first, and then surgery later. Thank you.
Excellent.